Thanks, Jillian. My name's Carolyn Ingram, and I'm coming to you today wearing several different hats, so I'll explain that. As Julian pointed out, I used to be a Medicaid director in New Mexico for about 8 years and brought up there a coordinated long-term supports and services program before we had the Office of the Duals and before some of the other changes. So I can tell you, thank goodness we've come a long, long way in terms of getting that support for states who really want to try to integrate care in some perspective. And so it's exciting to be here today to see how far it's come and all of the work that you all are laying out here. I then went on to work at the Center for Healthcare Strategies and helped states implement these programs across the nation and worked with a lot of the foundation folks that are here today. And now at Molina, am able to see kind of on the ground real time a health plan that operates in the MMP demonstration in most states and some of the challenges there. So I'm going to talk from that perspective here today and start with just a little bit of feedback on the framework that was laid out and then get into some other details. I think first, of course, Molina, we would support, and the managed care companies do, the permanency around trying to make sure that the MMP plan and DSNPs and managed long-term supports and services all get kind of combined in some way and with the same type of criteria across them. I think some of the changes that are laid out in the framework are great. I would, like Melanie, talk about a few more, but I don't want to duplicate. The one I want to add in terms of alignment besides grievances and appeals and things that we can do on enrollment is around marketing. We run into a lot of challenges in terms of trying to help states who want to market these integrated programs and having very different rules on the Medicare and the Medicaid side. And so I would try to see if there was any way to stick some of that information in there, even though you have lots of constraints. The other area I would go to is a little bit looking at some of the conversation earlier, but really trying to give some flexibility on implementation on the ground in some of these cases. We, in implementing the MMP and working through DSNPs and managed long-term supports and services, we have an array of individuals. So we have folks that are really high need that you started off the meeting talking about today. And they do need that kind of face-to-face assessment, but you have to be careful about how you go in and do it. A lot of them don't want us in their home, and they're very clear about that. They don't want us to integrate and come there. And so they don't have the desire to participate in the same way. And so there needs to be some flexibility now written into the program. We've learned a lot, I think, over the years about how to do that and the best way to do that. The other is there needs to be some type of balance of when to involve a PCP. For a person who's got a chronic illness, the PCP may not be the right person to involve. If you have somebody with cancer, maybe it's their specialist, it's their oncologist that we really need to be involving in the care planning that goes on there. We also really think that the care plan needs to have some flexibility around what the person really wants. If we have somebody who's a little bit higher functioning that we've gone in and assessed, they're able to get around. They have a lot of supports, and I think in particular of my grandparents, for example, when they were going through this process, they had a lot of supports to be able to live in the community if we got them set up there. So sometimes you have to provide that intensive care planning at the beginning, but then after that, we don't need all of the constant every 6 months face-to-face type of things. You can get somebody set up, and we can start thinking about using our valuable resources towards the populations that really need it, because we know, right, that state Medicaid agencies are struggling with coming up with the money for these types of programs. And then once they bring them up and start assessing people, they complain about the woodwork effect, where they're just spending more and more money on the individuals, and they're not seeing in the short term the cost savings, because obviously it takes a little while to see some of that cost savings. So I think thinking about how you spend that valuable resource is really important. And then I want to go to just the slides that were there before around payment policies. A lot of managed care companies add or bring to the table what they call value-added services. It's a great term, but we don't do a great job at the state level or at the federal level for accounting for those in terms of our payment and incentivizing those types of payments. So for example, at Molina, we pay for different housing models, and we're kind of experimenting across our health plans with those models. We have one in California called Project 25 that a lot of people here are familiar with that we participate in. We're developing a drop-in center where people who are homeless, because they don't really want to be housed sometimes, want to just be able to come in and get a sandwich, take a shower, maybe have their wounds checked at the clinic next door. So we're developing these different types of models, but there's really not recognition when rates are built actuarially to account for that, or some of the other value-added services. So I would argue that when you're looking across this, we need to really think about ways to account for those value-added services when you're doing the actuarial buildup. And there are ways to do that follow the CMS guidelines. but we need to work with actuarial firms that are out there. Most of the states contract with all the same firms. And we need to work with states to be able to have some of the creativity to figure out how to pay for these types of things. That way, you'll get more incentive for health plans, not just Molina, but across the board to participate in doing some of these social services that they want to bring to the table. They're trying to think of creative ways to do that. It's just trying to also get some of those incentives on the payment side. So I'll stop there and turn it back over to you for questions.